Hello, good evening. My name is Rashawn Jefferson. I am the chair for the the Physical and Mental Health Committee for Atlanta Suburban Alumni Chapter. Thank you for joining us for tonight's Mental Health Monday series about what you need to know about bipolar disorder. Tonight, our panelists will be Dr. Barnett and Dr. Woodford, and our moderator will be our co-chair, Cherie Hill. Cherie, I'm going to turn it over to you.
Hi, good evening. Thank you for that introduction. We are so thrilled to speak with you tonight on the topic of bipolar disorder, and we have two distinguished panelists here this evening. I myself am an OBGYN and often will have patients that have this condition, but these two are psychiatrists. They are the experts in diagnosis and treatment, and we can't wait to hear what you have to say on the topic. So to kick things off, I'll first introduce Dr. Woodford. She is from Virginia Beach, Virginia, by way of Greenwood, South Carolina. She's resided in the DMV for nearly 20 years. She completed her undergraduate studies at Howard University, where she earned a Bachelor of Science degree in biology. Dr. Woodford obtained her Doctorate of Medicine from the George Washington University School of Medicine and Health Sciences. She currently works as a second-year resident in psychiatry at Howard University Hospital. Dr. Woodford discovered her passion for psychiatry while in medical school, but knew at an early age that she wanted to be a physician. She served as an ambassador for the HBCU Cares Behavioral Health Program and appeared on the Black Psychiatry YouTube series. She aspires to specialize in addiction medicine or maternal mental health. I'll cheer for that as an OB at the conclusion of her residency training. Thank you and welcome, Dr. Woodford. Next, I'll introduce Dr. Golden Barnett III, who is currently the medical director for Willowbrook within the Tanner Health System here in Georgia. Dr. Barnett is a board-certified adult psychiatrist, and he completed his bachelor's and MD and residency education and training and supervision at Emory University and Emory University School of Medicine. His extensive training includes his tenure at the Grady Health System, covering inpatient, outpatient, opioid treatment, as well as psychiatric consultation services within the emergency department and other medical units. He has over 18 years of patient experience and continues to advocate for mental health, supporting families and patients recovering functionally to regain quality of life. And we are so thrilled to have him for the second time as a panelist for our mental health webinar. So welcome to you both. Well, what I'd love to do is kind of set the stage. I think many of us, especially looking through kind of the lay lens, have an idea of what we think bipolar disorder is. But truly, what is bipolar disorder? How do you make that diagnosis?
Dr. Woodford, would you like to go first, or?
Absolutely, sure. So I'm one of always going back to just looking at the root of a word. So even with just looking at bipolar, thinking about bi, two, and then pole, two different poles. And with that, we're thinking about a mood disorder. So something where a patient's going to come in or someone's going to be experiencing changes or trouble with their mood. Their mood, when you think of your mood, it can be up or it can be down. And so those are the two ends of the pole. And with regard to your mood being up, you may have like an inflated self-esteem. You may have lots of energy. Whereas on the other end of the pole, you may be very depressed. You may be experiencing periods of time where you're having trouble getting out of bed, low energy. And so with bipolar disorder, we're looking at changes or dysregulation in that mood. They can go from being really up to being very low. They can be somewhere in the middle. But for us to make the diagnosis, we're considering things where we are noticing changes with the elevated mood as well as the depressed mood. And it's a combination of the two. There are two different types of bipolar disorder. There is bipolar 1 as well as bipolar 2. bipolar 1 disorder, we're thinking about more exaggerated symptoms of elevated mood. A patient may come to the hospital and, they are having trouble sleeping. They're having elevated energy. We consider that like a manic episode. This may go on for a period of a week. They're irritable. Just this consistent couple of days where they're having elevated energy, poor sleep, maybe feeling like, they're irritated or explosive. Those are some things that we're concerned about with bipolar disorder. And the true definition is that with bipolar 1, they have this episode for at least a week. They may require hospitalization, and it's not always accompanied by the depressive symptoms. Whereas bipolar 2, they may have a combination of the two, but they don't have that elevated mood or that manic episode that I've first mentioned.
And in addition, if I might add, there is a degree of severity that goes along with it. So whether a patient or client has bipolar or not, a number of clients that we have, their family may say that, hey, this person's up and down, they must have bipolar. We will also hear people describe schizophrenia like that, which it is not. But with bipolar, exactly what Dr. Woodford said, but there is again, a severity to it that they are notably different than their usual selves. So if someone is sort of up and down in their mood and it's not really extreme, but hey, they're pretty happy sometimes, and then they're kind of gruff or kind of blah, that may or may not be like a bipolar 2. Of course, we would need to evaluate that person and look for other symptoms like impulsivity, and as it regards sleep. Are they not sleeping at all? Do they not want to sleep? Are they over-invested in other activities or thinking? So for instance, someone might be up because they are just cleaning the house and they're just going over and over, not from a OCD kind of thing, but they're just compelled to clean, or if they're working on a project. So you can have very active people and very I don't want to say imaginative, but very creative people that maybe at the onset of an episode can really like what they're feeling. Because one, they don't need to sleep. They get all these interesting ideas, which may or may not translate to something reasonable that family or friends could appreciate. But it might start off that way. And if they don't need sleep, they have that much more time to create their next business project. And then, like I said, it can get more extreme beyond that, to the point where they're not, some of our clients may not purposefully come to see us. They may be coming to see us against their will. One, families brought them in. Some things that we may talk about later, they may have gotten a court order to have an individual brought in because they were concerned about their behavior and safety for themselves and the community. Or we're seeing them in the emergency room because there's been some motor vehicle accident because they've been impulsive, driving erratically, or someone has picked them up because they were acting erratically on the street. And it could be to the extreme where people may think that they're on drugs and they're not. And again, police have brought them in, and either we're seeing them in the emergency room, or for those of us that work with police and jails, we may be seeing them there. So I do want to stress that it's the severity of their presentation, and there's a severity difference between the bipolar 2, as Dr. Woodford was saying, and bipolar 1. I'm sorry, hypomanic presentation and a manic presentation. Because once an individual, just technically speaking, diagnostic wise, once they have the diagnosis of bipolar 1, you don't go back to bipolar 2, which is a lesser, less disruptive form of it.
The bipolar 1 is the one where they're more manic and severe, and then
Correct. 2,
they're more hypomanic.
Correct, because 2, this is the only diagnosis in our DSM-5, in our DSM, I should say, because it was the same in DSM-4, where hospitalization can be part of criteria for a diagnosis. So if someone is manic or hypomanic, but that has led them to be hospitalized for that, that automatically pushes them to a manic episode and therefore
Gotcha.
a bipolar 1. So someone can still have a hypomanic episode or less intensive, whether they're in treatment or it hasn't progressed. But once they've had that bipolar 1, and that's a good thing because it keeps us mindful of, you know, how closely we should monitor an individual in their symptoms or their recovery, and their overall stability.
Makes sense. So as I'm listening to this, I know sometimes I'll see patients who come in and they don't have a clear diagnosis. I have seen where it's, you know, bipolar, schizoaffective disorder versus schizophrenia. So I know that's a lot of different or several diagnoses, but maybe if you could touch on first, what's the difference then between bipolar and schizophrenia? Like, is this elevated mood different than psychosis? What then makes the difference or the distinction for the diagnosis of schizophrenia versus bipolar?
So I will say, you know, especially being a resident at Howard, we are very quick to look at those different diagnoses and slowly start to pull apart them, because thinking about schizoaffective as well as bipolar disorder, you can't have those two diagnoses at the same time. So we're constantly removing some of these diagnoses that have been given to our patients. A lot of times they'll acquire those if they've gone to different providers or they've been at different hospitals. For the difference between schizo, really anything. So there are a couple of different psychotic disorders, and they carry the titles of like schizophrenia, schizoaffective disorder. And with psychosis, it's a little bit different than the mood disorder. So bipolar falls in the category of a mood disorder, and we're concerned about mood. Whereas a psychotic disorder, like schizoaffective or schizophrenia, we're sometimes concerned about we're concerned foremost about the psychosis, but there may also be a component of mood as well. So with schizophrenia, the patients or the clients will show what we consider psychotic symptoms, where they may start to experience things that aren't, their perception is not correct, meaning they may see something that is not really there, but they're experiencing it, or they may hear things that other people may not hear. So they are sensing a stimulus in a room or responding to something or experiencing something where our perception, we're not perceiving that. And so those individuals with psychosis, those types of things, they have disorganized speech, they have a hard time processing information and relaying that to other people. So when they're having a conversation, they may appear disorganized with how they're conveying the information. So with them having things like a disorganized thought, the perceptual disturbances, such as the visual hallucinations, as well as the auditory hallucinations, those fall in line with schizophrenia. And schizophrenia is usually a period of 6 months. So we would be at least following them for a while before we make that diagnosis. With schizoaffective disorder, they have a component of the psychosis, but they also have a period of time where they experience mood symptoms. And with regard to the mood symptoms, they can be like the elevated mood or the depressed mood. So not only do they have this underlying psychosis, they also may have a period of time where they experience at least a 2-week period of depressive symptoms, or they may have, similar to when we talked about bipolar disorder, some of the bipolar disorder symptoms. And so those individuals would carry a diagnosis of schizoaffective disorder.
Okay, well, thank you so much for laying that out. I know that
Can I add to that?
Oh, of course, definitely.
So for having practiced in the hospital as long as I have, it is somewhat sad that an individual literally can come into an emergency room, and I don't put much blame on the emergency room docs. They have a lot of things to be aware of and to cover, and they're usually treating not only the patient or client themselves, but family and others that come with them. But in one visit into the emergency room, they could say a patient a 25-year-old African-American male with a history of, they will literally say schizophrenia, bipolar, depression, generalized anxiety. They list every single major diagnosis.
I see that all the time.
And it's very frustrating because essentially on the psychiatrist end, essentially when I looked at it, I said, so you've essentially told me nothing. One of the big things for schizophrenia that I really hold to, because there are many different causes for psychosis, and schizophrenia is one. But schizophrenia and schizoaffective, they're what I would call our primary psychotic illnesses. Because individuals with bipolar who have manic episodes can have secondary psychosis. So can individuals with depression. So we separate that from schizophrenia and schizoaffective disorder by schizophrenia and schizoaffective disorder. From my perspective, the biggest thing that we have to use with that, in addition to the 6 months that they have had to have these symptoms before that formal diagnosis, is that they have to have some decompensation and or loss of some level of loss of functioning, of whether it be social, functional. They may not be able to function at the same level that they had before the onset of their illness. So you could have a college graduate that maybe has run their business that is no longer able to run their business, maintain a relationship with loved ones. So there's a big change there.
Okay.
I emphasize that because we have so many people, again, that can have psychosis related to just being depressed for several months and it being very severe, or other medical issues or substance use. That's a big thing. And that can be a big thing also when it comes to determining if someone has a bipolar versus what we call substance-induced mood or psychotic disorders. So you can have a manic episode that's due to cocaine or methamphetamines, but I cannot diagnose them. Technically, I cannot diagnose them. There's art to this, so you might have to, but you technically can't diagnose them with bipolar. If with that episode, it's reasonable that their substance use within 30 days likely contributed to that mood or psychotic state. And with schizoaffective, the primary is schizophrenia. So more often than not in that illness, they are experiencing more psychotic symptoms related to that schizophrenia. And secondarily, and only episodically, do they have maybe some mood symptoms of depression or manic-like symptoms or mixed depression and manic episode. With bipolar, individuals aren't having psychotic symptoms outside of these episodes. Now it does get a little bit difficult, particularly as providers, because more and more we're using similar medications for the treatment of schizophrenia and schizoaffective, as well as bipolar, and to a certain degree, depression. So one can argue, as our knowledge of what potentially causes schizophrenia and bipolar episodes or manic episodes, that there's possibly a spectrum.
Right.
But with bipolar and also with depression, again, someone is not necessarily going to have discrete psychotic symptoms outside of that person having a manic or depression episode. And along with that, and to be fair, I can't recall this specifically when it comes to bipolar, but even for depression, if someone has psychosis secondary to their depression, that automatically knocks the severity of their depression to severe. We don't always use the qualifiers of mild, moderate, and severe, at least in coding, with bipolar, but you could. But it's not necessarily that severe has to be connected with, like we say, secondary psychosis. And one other thing that I would add is usually not nearly as bizarre as the psychotic symptoms that an individual will experience with schizophrenia. It's usually, a technical term would be mood syntonic, but what we'd otherwise say is it goes along with how they're feeling.
Got it.
So if someone is manic, well, I've had people tell me that they were the president of Sony Records. They've told me that they were a combination of Jesus and Muhammad while they were stripping nude in a hotel in downtown Atlanta. So they can have psychosis that matches that. Similar to if someone is depressed, individuals can have an experience of, hearing loved ones or hearing spirits tell them, just come and join us, or you're worthless, no one loves you, those sorts of things. So it does get complicated, but
yes, I was like, I think we've got a lot to unpack with what you said there.
And one last thing I will add, because this is actually what I wanted to share first, but I got excited. There is documented racial bias when it comes to diagnoses. There are a number of racial biases, even in OB. I'm pretty sure you're aware of that in terms of how Black women can be perceived, their pain thresholds, and things like that. When it comes to mental health, there is a propensity to diagnosing African Americans, and definitely African American males, with schizophrenia off the bat, versus further evaluation and a more reasonable diagnosis of bipolar or manic episode. Which, one last thing, mania, bipolar and depression we would call them episodic. Individuals can have lengthy episodes, so they can last usually more than a week to a month, but they can last 6 months, if not longer. But it's harder to do that nowadays as opposed to 60, 80 years ago.
Right.
Whereas schizophrenia, they can have episodes which worsen, where their symptoms worsen, but it is pretty consistent and chronic.
Okay. Well, thank you for those points. I wanted to move forward to the chat is blowing up with some questions, and I think that you'll be able to probably touch on a lot more details as we address some of these questions. So the first that I'd like to do is talk about age, and I have 2 questions that I'd like to pose, and maybe each one of you can take one question. So the first will be, how does this differ in the pediatric population? Do these diagnoses present in childhood?
I can handle that one. Okay. So from a diagnostic perspective, in these instances, we use the same criteria. However, it is complicated with a little bit more complicated with kids, because we do have other behavioral diagnoses that we are more prominent as children that we have to be aware of. So you can have some parents come in and they're concerned with, if their child's attention and their impulsivity is that ADHD, is that, are they bipolar? I had a family member ask me, does this person have bipolar? I was like, well, it's bipolar, and no. The reason is, in that instance, that individual had some very significant behavioral issues, like what we would call, which we're not going to get into here, obviously, but conduct disorder versus oppositional defiant disorder. Although the criteria are vastly different, they can mask as manic-like symptoms when, you have a child that's potentially disagreeable or impulsive, destructive, seemingly irrational at times. And in addition to that, you can have, I don't personally like to do this, but you can have young children, I would say teenagers, that could also be impacted by personality traits or disorders, which is why you need, trained professionals to weed those things out. because the treatment for those illnesses and issues can be very different. Whereas bipolar should include medications as well as counseling. Some of the others that I mentioned don't necessarily have to, and the emphasis may be on counseling and family counseling. But children can have depression and manic episodes in their child age years, 5, 6, and 7. We don't see that very often, but it can happen, and definitely as teenagers.
Okay. So now on the opposite end of the age spectrum, an audience member asked, could you talk a little bit more about older adults, baby boomers, for example, who may have been diagnosed with bipolar disorder at a young age, but are now in denial about this diagnosis. And so they may be then leaning on these kind of unhealthy behaviors that you alluded to before, whether that's cocaine, alcohol, maybe they're having some of these manic episodes and doing frivolous spending in order to cope. And so then the kind of part 2 to that question is, how can family or friends get them to, help, whether or not that needs to be medication or therapy, and how do family members move forward if that person is refusing treatment?
I think I'll at least touch on what Dr. Barnett started to mention before about Black individuals being misdiagnosed with schizophrenia versus bipolar disorder. That kind of carries along with the history and consistency of mental health in general. There are times where we are not diagnosed and we go undiagnosed for a number of years. And similar to the question that's being presented now, I have this relative that has been struggling with this and coping with substances, is in denial about what's going on and has not been able to get the appropriate care. We have seen a number of studies in at least 2018 where Black people are disproportionately not receiving the care that they need, either outpatient or for treatment, hospitalizations for bipolar disorder. With regard to, helping a family member identifying things, the conversation really starts now with destigmatizing, this idea of, mental health being something that is not as important as, let's say, your sugar or your blood pressure. I think it's really difficult for us to quantify someone's mood or what they're experiencing, because it's more of a subjective or their own account of what's going on, rather than some of the, the measurements that we can take for someone's blood pressure or their sugar. So it's really hard for us to say, oh, well, you're sad today versus you're very excited tomorrow. Really having a conversation about how you're feeling with your family members, noticing different patterns, observing how they cope, allowing them to really express, what's going on with them, tapping into some of the resources in your community, encouraging them to go see a health professional. Those are some of the steps that may seem very small, but they actually do help in the long term, at least with our patients here in the district. So with regard to, acknowledging what they're experiencing, looking into, how are they coping? How are their moods changing? What are some triggers? What are warning signs that I'm seeing? Are they on social media more? Are they up all night, with these thoughts? Are they sad? Are they depressed? Just trying to pinpoint and normalize, their feelings of what's going on and having a conversation. I think with us, it starts with having a conversation about what we're experiencing to better help us figure out, how we can best, tackle it and deal with it. And then the last part of that question, I think you mentioned, if they're reluctant to get help, how do we tackle things like that? So, one of the things is education, educating the family about warning signs that they're seeing. When it is a feeling that the family members, I'm really worried about this particular individual, they're doing something to harm themselves, getting appropriate help then. with regard to most of the patients with bipolar disorder, a lot of times we encounter them in a setting where they have put themselves at risk or others in danger. So they're coming to us, under police, in police custody, but not under arrest, or they're going to emergency psychiatric unit. So I would say in that regard, trying to find resources in your community where you can best help address those things. And I'm not from Georgia, so I can't really speak to what's available there. I'll defer to I'll defer to you. But at least trying to identify them and starting the conversation initially.
Yes, and I could add the Georgia Crisis Access Line, or GCAL. So individuals you can literally put in a web search for GCAL, GCAL, and they have a number of resources, which could include telling family or the individual to come into the emergency room for assessment, or they could actually have crisis members come to the home, mental health crisis, to assess the individual. And depending on what is shared in the call, they may or may not have, sheriffs or authorities come along with them. I would recommend, before it gets to an extreme level, to be willing to do, some level of an intervention, to really challenge that person and really encourage them to, to seek treatment or support, but also relate to them that that they are loved and that you appreciate everything about them. Because that's one of the biggest things that we have when individuals come in. They feel like everybody is against them. And we spend a lot of time letting them know, hey, I've talked to your family. You seem like a cool, guy or gal, whomever you are. And the only thing I've heard from your family is that they're concerned about you, they love you, and they're scared about you. And I'm seeing them on the inpatient side of things. So right. I'm seeing obviously the more extreme. And as I mentioned before, again, on the extreme, if one has to do this, and this is regarding severe depression, individuals who are impulsive or suicidal, or they have had some significant changes in their behavior, and you don't know why, but there's a concern of risk of harm to themselves or others. And this could also be as it relates to alcohol or substances. We do have probate court commitments, so individuals can go to the probate court. There have to be two individuals that know the person, and that can testify, given written testimony to a judge, under risk of perjury if they do not tell the truth, to document their observations and concerns. And then that judge, typically, I almost 100%, if you have two individuals that give reasonable concerns, will put in an order for that individual to be brought in, at the very least, for assessment. And most psychiatrists, most clinicians, when they know that individual has been brought in on that court order, will typically still hold that individual, even if they look good in that 5-10 minutes that we may see them in the emergency room, or nowadays on Zoom, or if we're doing a tele-evaluation. Because me personally, if an individual's come in, even if after 24 hours they're on my inpatient unit, doc, I'm fine, I shouldn't have been in here, I always tell them, I'm glad you're doing better. Whatever we're doing, we need to keep doing it. But you essentially had 2.5 people get you here. The 2 people who testified, and I count the judge as a half because the judge usually hasn't seen the individual themselves. Mm-hmm. But they felt that it was valid enough to have them in there. And if the emergency room doctor happened to see them was on board, I'll add them in there too. And that usually takes the burden.
Is that what a therapeutic intervention is going to the probate court, or is that something different? I heard you mention that, and someone actually asked it in the chat. So I didn't know if you could kind of expand on what is a therapeutic intervention.
That is an intervention. So okay. Like an intervention would be a more traditional intervention. Like if someone were using substances, like a family gets together and sit somebody down and say, hey, we need to talk. We're concerned about you. We've seen you drink a lot more. You're not going to work or school. We've seen you driving after you've been drinking, that sort of a thing. But instead of alcohol, we're talking about mental health, right? So I would say that's a therapeutic intervention. The courts, and by that point, it's not therapeutic. It's an immediate safety concern. And in that instance, it can become somewhat adversarial because you're having someone forcibly come in,
Right.
and you're going through the courts to do it. So initially, the patient or clients themselves can have a little bit of anger or frustration. So that's why I say I would encourage individuals to have more direct intervention themselves, meaning sit down and talk with their loved ones about their concerns, and not hesitate to make it seem like, well, I don't want to embarrass them. It's not about being embarrassed, it's about them being well.
Right.
Yeah.
So kind of summarizing what both of you said, it sounds like if you're looking to support someone in your family who has this diagnosis, really starting with a conversation and kind of destigmatizing literally within your own home is a good first step for family members or loved ones to support someone with a diagnosis. So I think that's something simple that we all could do if we're recognizing some of these symptoms in someone we love. Speaking of family or friends, is this hereditary? I mean, how concerned should we be if we do see this behavior or we learn of a family member who is diagnosed? Is it hereditary? Do I then need to go and get checked out, for example, if you have a family member who was diagnosed?
So we do know that genetics does play a role with bipolar disorder. We've seen that there is an increased risk for first degree relatives. That risk is between 5 to 10%. And then there is also an increased risk for siblings as well as twins. So with regard to thinking about like genetics and family members, one thing to consider is like the age of onset. When did you notice that your brother started to have symptoms? I've seen a couple of patients, sets of twins, where one brother will started to have issues maybe the first year of college, and then subsequently maybe a year later or 2 years later, his brother, which was probably about 18 months apart from him, also started to have similar symptoms. So being mindful of those conversations that you're having with family members, as well as like the history of things that are going on with your family, is certainly helpful.
Thank you. So going back to ways that we can provide support for those that maybe are one step removed, for example, teachers, what suggestions would you give to a teacher who may work with a student who is diagnosed with bipolar disorder, for example, but doesn't necessarily have the training to de-escalate if they are in a heightened state? Do I need to repeat the question? I know that's kind of a tough one.
No, that's just a very difficult question. There are some schools that, depending on their counties and depending on the resources in those counties, they may have some mental health providers have some presence there. I am by no means here to represent Tanner's interest in the community, which is not in Atlanta, it's just outside of Atlanta. But we have a number of mental health nurse practitioners and therapists that are stationed at several of the schools in Carroll County. I think it's something that a number of other counties and facilities could also benefit from having, because even the school nurse is not necessarily going to have on average, have a great command of how to de-escalate that. And a young individual having a manic-like episode, it will inevitably require a good deal of communication between the teachers, administration at the school, and the family. No different than if you're having, then you're working with a child that has spectrum developmental or disorder or ADHD. But I would recommend actually calling an institution like GCAL, because we've seen too often where we call police to come in to do things where they have less training and ability than the people that we have on staff, and that goes for the hospital too. We've had, not at the psychiatric facility, but at medical hospitals, individuals acting out related to mental health, and for some reason we call police, and then someone's injured, and now someone has charges, which are inevitably in most cases going to be dropped, but it was unnecessary to begin with. The officers do not have any more training and have less training in that regard than the average care provider in the hospitals. But the same thing would go for the schools. And so I say all this to say I don't really have a great answer, because it really depends on the institution, the resources that they have available in that particular school, as well as the relationship that is established between the child, the teacher, the parents, and the administrators and leadership of the school.
Thank you for that insight. I definitely have seen that in my own institution at the hospital I work at, where the police or hospital police are called to de-escalate, and then they may or may not know the proper de-escalation techniques, and we're then calling psychiatry to try to get some of those like acute on the job training, and it's definitely a challenge. And I'm hoping that's a solution that I think maybe our public dollars can go to really work on more training for those situations. I wanted to talk.
When it comes to,
oh yeah, go ahead.
And outside of schools, when it comes to helping adults, and I know that we've mentioned that sometimes, we're seeing patients or clients brought in because they're in police custody, sometimes with and without charges. But many counties now have mental health courts, just as they have drug courts, to redirect individuals from unnecessary and potentially harmful incarceration into programs in their intensive outpatient programs that encourage them to be engaged in their treatment, maintain their follow-up, and hopefully decrease future episodes that not only could be disruptive of their lives in general, but can lead to criminal legal issues.
Right. Yeah, and then trying to get a job and all of the other things that can come with making hardships even worse. So we've talked a little bit about kind of the family risk factor for bipolar. Are there any other contributing factors that could lead to getting a diagnosis of bipolar disorder? So for example, the substance use, is it the substance use that then leads to bipolar, or were they potentially already masking symptoms with their substance use? Stress, the COVID-19 pandemic, is a nervous breakdown a risk factor for bipolar?
So what we typically see is that clients will come in and they'll start to notice different changes in their mood. We call it like a prodrome, meaning they start to experience periods of times where they're more irritable than they were before. Their mood is changing. They may be feeling depressed. They may be feeling very up. And so for us, our concern is that, how are they coping with those things? So you mentioned, is there a risk factor with substance use? We do see that patients that are presenting with sometimes a manic episode are more likely to use substances. But we haven't tied a direct correlation to substance use with regard to that being a predisposing factor for a client to have bipolar disorder. It's more so that the substance use, we have a hard time making the diagnosis of bipolar disorder. And like you mentioned, it's masking some of the symptoms, or we may confuse some of the symptoms of their substance use with now their manic episode, or some of the experiences, the symptoms they're having for an underlying diagnosis of bipolar disorder. So it makes it a little bit difficult for us to kind of tease out, is this in fact a substance, or is this the onset of bipolar disorder? What we will see is that there are symptoms that vary from client to client when they initially start to have that prodromal phase where they're experiencing those symptoms that are later going to be full-fledged bipolar disorder. That may vary from person to person, but for us, at least, it's hard to make the diagnosis in the setting of substance use, and we can't really make it at that point. But we do see that clients that do carry a diagnosis of bipolar disorder are more likely to use substances.
That makes sense. Okay, that makes sense. I was wondering if you guys could also touch on this concept of a nervous breakdown. Is a nervous breakdown something that leads to bipolar? I know that's kind of a lay term, but if you could speak to that, I'm sure you've heard people say that before.
Well, you're correct. It is a lay term, which could mean any number of things. That can mean someone just really got in the moment, was really anxious, and maybe they had a freak out. Or it could be someone that has gotten really depressed. It just, when I hear nervous breakdown, that's another thing that I know they're trying to tell me that someone has gone through a significant episode, but I really haven't learned anything more than that. So it really is a matter of just getting more history from the person themselves, and what we call collateral history, or history from family as well. Were there any triggers, like some significant emotional loss, the death of a loved one? Like you said, COVID. We did have COVID has been very interesting. It has both pushed a lot of people into illness, but has also driven a lot of people out of the hospital because just how busy it's been in the medical side. And sometimes it's been harder for individuals to get into the inpatient psychiatry because they get turned away from emergency rooms. And thankfully, all of that is getting better in the meantime. But yeah, breakdown can be, just a very brief aside with regards to a patient telling me a breakdown. There's a gentleman who states that he had a breakdown when he was in college. He went to the emergency room, and this was decades ago, but they said he had a breakdown. And he said he had 2 breakdowns in college. By the time I assessed him and was working on some different things, he was 40 years old. He had a son who had been diagnosed with schizophrenia and had similar episodes around the same time that he had when he was in college. And those breakdowns were his initial psychotic episodes. There were some other things that were going on with him that kind of masked that. But he also described that as a breakdown. So it just really depends on what that individual is experiencing, and in some way that they can communicate to us, and we can see some of that as well.
And you brought up the point of being episodic, and trying to make sure I'm keeping all this information straight. So bipolar tends to be more episodic. Schizophrenia tends to be more chronic. I know you mentioned bipolar 1 being more severe. Is there like a time frame between these episodes? Do they tend to get further apart? Do they tend to get closer together? Is there any sort of pattern to these periodic episodes that someone with bipolar may experience?
So typically, the more episodes one has, the more episodes one can have. So we really, for the first episode that someone has, we really get on it and say, hey, this is what you're experiencing. And although there is a chance that you won't have another episode, we want them to be in treatment for at least 6 months to reduce their risk of having a second episode. And this goes, and I'm just speaking about mood episodes, so this can go very well for depression as well. But the more, there's a 60% chance of having a second episode, and a 30% chance beyond that, and a 30% additional chance with on average of someone having another episode. And typically while we call these episodic and most individuals recover back to their usual level, over a period of time, when someone continues to have these insults, it's no different than our physical medical counterparts, where, you know, you keep suffering from high blood pressure, you're going to have some consequences from that, right? And you can have individuals after, there's no specific number. And again, I'm speaking as an inpatient, so I see a lot of individuals that come in, we get them on medication, they go out, we see them in 2 more months because they didn't keep up with their medications. And it has progressed to some of their symptoms almost appear somewhat chronic. They're starting to display things where that now gets more complicated, because you can have another psychiatrist now see this person who doesn't know this person's history, and you've worked with them for 10 years, but they've seen them and this person looks like they're schizophrenic now. So I know I was saying earlier that there is a difference, and there is, but with, you know, protracted illness and frequent disruptions in treatment, you can have worsening symptoms. And ultimately, you can have individuals that aren't necessarily resistant to treatment, but the treatment that they had been on can seem less effective. And so we then end up doing more complicated things, which in and of itself makes it more difficult to maintain compliance with.
Oh, that was
So
just
yeah, there's
beautifully worded. No, I really loved how you made that connection to, like, with the high blood pressure, right? Because we've all seen friends or family members who are on dialysis, and that's kind of like an end result of long-term hypertension. And so the same thing with mental health, if it goes untreated, it's going to be that much more disruptive and troublesome to treat. So thank you. That was very well said.
I was also just going to add, it's going to vary from client to client as well. Like, we see different patients with blood pressure. You know, some people may be well controlled on one medication versus other individuals who aren't. So with regard to that, it's still very important to consider that it may vary from client to client.
Excellent. Thank you. I have a couple of more questions about diagnosis, and then we will start getting a little bit more into treatment. I love the fact that you guys both are able to prescribe, so we'll talk a little bit about medications and such. But going back to the diagnosis, I know we talked about COVID-19. I know it's probably a little too early to know about population studies, but just kind of anecdotally, what you all are seeing clinically, has there been a rise in bipolar or schizophrenia diagnoses, whether that's in men, women, both? If you could comment on that.
I can speak to what I've seen on inpatient. What I have noticed, I will say that with regard to diagnosis, we're seeing more of patients decompensating, meaning they carry a diagnosis or they have had bipolar disorder or schizophrenia for a number of years. With COVID, they're no longer able to go to their outpatient appointments, go to their group therapy that's in person. Some of their case managers that they may have contact with, they aren't able to have that point of contact. And so what has happened and what we're seeing is that a number of clients are now presenting to our inpatient unit or presenting to the emergency department in the setting of COVID and not having access to their medications, as well as being able to follow up. Also, with a lot of the stressors, you know, just thinking about the heightened stress with the pandemic, we are seeing people that come to the emergency department now with, you know, they already had a predisposition for bipolar disorder, schizophrenia, but because they're placed in all of the stress, they're presenting to the emergency department, and now they have, you know, an evaluation that they may not have undergone because they didn't have that stressor if COVID had not occurred. So what we're seeing is more patients essentially coming to the hospital, and subsequently, yes, sure, we may be able to say we have more of a diagnosis, but we're just able to see those patients a little bit more often than we would have had eyes on them if COVID had not occurred.
Yeah, that completely makes sense to me. I know you mentioned, Dr. Barnett, as well, people not even wanting to go into the hospital because they were scared of COVID. So then maybe things were getting worse. And so then they present in a more extreme way when they do come to the hospital. So going back to making this diagnosis. Are there any tests, like biologic tests, that indicate a predisposition? I know a lot of people do these 23andMe swabs, and you'll get these emails that say you're predisposed to different disorders, whether it's breast cancer or potentially dementia, etc. Is there a biological test for bipolar disorder?
No biological test. Obviously, when we screen for, family history, that is a big component. Um, there are questionnaires and screenings that can be very helpful, but we also use that in conjunction with our clinical evaluation. So with bipolar, an individual isn't going to be able to go in and be healthy and screen, for that risk. We don't have a test for that yet. So unfortunately, it's a matter of family and personal history that we typically rely on, and also individuals can actually have their first episode of mania in mid or late life. Other times they will have had or could have had a major depressive episode before then. Because of the potential risk and connection between depression and bipolar, for most of the patients that we treat for depression, we closely monitor for any signs or symptoms that they could be sweeping over to the other end, from a depressive episode to a manic or hypomanic episode. Again, just to be safe. But there's no screening that we have, unfortunately.
Okay. I had a feeling that was the answer, but I thought I would pose it to the experts, of course. Along the lines of how people present, I know you said if you are hospitalized, that can kind of bump you up from a bipolar 2 to a bipolar 1. What are the things that are bringing people to the hospital? I know you mentioned impulsivity. So is it things like suicide attempts, or is it their substance use? What is it that you are seeing that brings them to the hospital?
So I would say that it's actually possibly all of the above. There are times where, someone may be in that phase where they're really, or the episode where they're really depressed, and they come to the hospital, and then we do a screening and a bipolar disorder screening, and we were able to find that there are periods of time where they feel really up, and we were able to make, keep an eye on that and later make a diagnosis of bipolar disorder. There are other times, and most of the time in the emergency department, we're finding that they're coming in with an emergency petition. So they were a danger to someone else. Or a family member felt that, they weren't quite themselves. They were concerned, and they called the police, or they called a crisis team. And they were doing things like on social media, posting things that were just very concerning to family members and loved ones, or they were spending a lot of their money. With the impulsivity, some may go and spend their life savings and engage in risky behavior, having multiple partners, not being safe. Other instances may be times where, they also, in the setting of their manic episode or them being depressed, they're starting to use more substances. And with them using more substances, they, are putting themselves in danger and now being brought to the hospital, or loved ones bringing them to the hospital because they're concerned. There also is we also see them come to outpatient. So a loved one may be concerned and actually have them come in to be evaluated. So sometimes it's other individuals noticing a change with the client. And sometimes the clients might also, in some of the, bipolar, considering bipolar 2, their own changes in mood, as well as things that are going on with them.
Thank you. Well, I have another question from an audience member. I'm going to read it to make sure that I capture the sentiment. So, what if your spouse stonewalls every month and you ask why they aren't talking. They say they are feeling down, but they don't know why. However, they're refusing to go to therapy. How do you handle that?
I would encourage that individual to, I'm not saying, obviously in the question, we can't tell how direct they've been, but to just be really direct and share their concern. Because we can easily kind of just dismiss, like, why won't you talk to anybody? I don't need to, I don't want to. And if we don't hear anything else from that person, it's just like, okay, they said what they had to say. And it really might not be conveyed why we're concerned about whatever it is that we're concerned about. So if it's a matter of, um, one of the terms that we use for like mania, and the opposite term that we use for depression is hedonia, hedonism, like hedonia and versus anhedonia. So it's, interest in pleasurable things, just like what they used to have in the islands, like hedonism, everybody go on a parade and with all sorts of levels of undress and just be partying. So with mania, there's a heightened sense of pleasure seeking. So as Dr. Woodford said, individuals can have multiple partners. That is different than usual. Individuals can have multiple partners, but it's like, now I wouldn't have normally done that before, and now I'm having multiple partners at one time or sequentially, and in two instances with two different individuals, and luckily nothing happened. Had a young woman travel hundreds of miles from her home, and she was in Atlanta, and she went door to door at a motel offering herself before someone said, "Hey, what's wrong with you?" and got her into the hospital. You could also have individuals, it doesn't have to be that type of exaggeration, individuals who may become hyper religious, whereas they didn't really have any religious inclinations before, or if they did, now it's really extreme to the point where, their fast is indefinite. They're or they're praying incessantly. And you can have the opposite, where individuals aren't interested in anything. They may not care about things that they normally would, like, hey, talking to your kids, adult or young, or your grandparents, or fishing, or games, sports, or anything like that. So I bring that up, for instance, in this instance, if it's a matter of being able to share with that person, I'm concerned because I don't see you doing those things that you normally like to do, or you're off to yourself. We don't talk. You don't look at me in the eyes. I've heard you, I think I've heard you crying. And that's just being really direct with them and saying, I or we, if there are other individuals that are or can be involved, we're here for you, and we love you. We want to help you, but this may be beyond us. And again, I'm kind of making up a situation from the question, but from what was framed in the question, I would say that would be what I would emphasize is, again, being very direct, loving, but giving examples of what you have observed and changes, to say, hey, I see something going on, and maybe that's the opportunity that he needs to share, like, okay, maybe something is worse than it was, or for that person to realize, I haven't been covering this up. I thought I had been, but I hadn't. And then going from there, I try, again, just for the patients that we see inpatient, they're on the more extreme end. Individuals who are receiving inpatient care for all of our mental illnesses look like a different population of individuals that are regularly an outpatient.
Right.
So I try not to go to the extreme when I make recommendations to individuals who haven't gotten to that level of care. The other thing I would recommend is encouraging that patient to see their providers but also to get connected with a psychiatrist, a therapist, counselor. A lot of mental health is done by family medicine practitioners. Uh, so the ones that are dealing with the mild to moderate depressions, the clients themselves feel like, I don't want to see a psychiatrist. I ain't that bad, doc.
Yeah.
And even
Oh, yeah.
sometimes
I hear it in
the
my
providers
office.
themselves, like, you're not that bad. I can take care of you, which in many instances they can. But I would suggest, again, making sure they're connected with any level and then progressing as their needs dictate.
Awesome.
I will agree with Dr. Barnett. I just want to jump in and say that a lot of times when our family members are not saying anything, just because they're not talking, it doesn't mean they're not telling us things around them. So just thinking about, any events that are occurring in their life, considering, is there someone in the family that could get through to this person? What else is happening? Are they not eating? Are they not sleeping? Just noticing all the things around them from a standpoint of how are they communicating aside from talking. But similar to what Dr. Barnett was saying.
Thank you.
And we haven't, if I could add one other thing, because I think Dr. Woodford and I have kind of gotten close to this, but mentioned this, but haven't. When it comes to stigma in our community, we will oftentimes we'll connect our mental health to our spirituality. From my own personal experience years ago, when I lived in a different part of town, I had to go through a couple of different churches because they had great perspectives on health, medical health. But when it came to mental health, some of the places really tied individuals' mental health to their spiritual connection, which I did not feel was fair, and spoke out about it against at the time. We need to reinforce that, and I don't give details to patients, but I will share with patients that I do have my own religious beliefs, and when they have kind of expressed, well, God will take care of me. I said, well, typically God works through people and things and the environment, but you have to be open to accepting it, right? Mm-hmm. So, most times, we don't specifically rely on God to manage our blood sugars, right? We'll say, thank God I got my doc, thank God I got my insulin, thank God I got my glucophage, whatever it is. And I'm just saying, hey, just take that perspective from the mental health as well. God is putting people in your life to help you work through this. Because again, we just had a number of individuals that will be very resistant to their mental health, supporting their mental health, in contrast to doing everything they can for their medical health. And they have this additional burden of, I'm not getting well because my connection with God isn't as good as it should be. And just letting that person know you're connected, just let God work through other people and things to get you better. Because that's a big component. It's not the only one in our community.
Yes.
And again, for a number of people, just believing that they have a weakness in their mental health, it's almost more of a core sense of being than how one's heart is doing or how
Right.
one's pancreas is doing.
Yeah, understood. I've seen that. Well, I wanted to spend this last about 10 minutes talking a little bit more about treatment. We've talked a little bit about seeing somebody outpatient, reasons that somebody might have to go inpatient. What could a patient, or if we have family members, support people on the phone here and they're gathering information, what would one expect for a typical treatment plan for bipolar? Is therapy enough? What are the main medications that you may offer? And if we could talk a little bit maybe first about the outpatient setting and then to the more extreme inpatient setting.
So I think the most important thing a family member can do, as well as a person coming, is to really tell us what's going on and what are our major concerns with the patient? So someone coming for outpatient treatment that, even though they're not severe enough to go to the hospital, but they're experiencing manic symptoms, they're not sleeping, they're engaging in some of those risky behavior things, they are expressing that their mood has not been well, and we decide, I think this patient meets the criteria for bipolar disorder, 2 versus 1, that'll determine how we best treat the patient. So the first thing would be to try to figure out exactly what is going on with the patient. What are our concerns? Is it sleep versus mood versus their depressive symptoms? And that'll help guide how we best treat the patient. So with regard to someone that comes in and we make the diagnosis of bipolar disorder and they're not sleeping, that's probably the first thing that we typically address is the sleep, because if they're undergoing even a hypomanic episode or a manic episode, we call it like breaking that particular manic episode and kind of seeing how they progress along there. And then once we're able to kind of get a better sense of, what symptoms they're struggling with, then we can start thinking about longer term treatment for the patient, managing their mood. And there are a few medications that help us do those things. And so with regard to mood stabilization, I'm not sure if people are familiar with medications like lithium, as well as Depakote. Those are medications that, when I see a patient that comes to see me for outpatient, if they've been following with someone else, I'm thinking, this is maybe being used to treat some type of mood symptom, and just thinking about like, okay, so if we're going to stabilize their mood, we've controlled their sleep and they're still having issues with their mood, so let's consider starting some type of mood stabilizer in order to best help with their mood. And then considering, once we've able to evaluate the patient after they've started that medication, because that takes some time to work, trying to go from there to determine, what additional medications we may either need to add or change.
Is there a role for anti-psychotics as well, or do you reserve that more for true like schizophrenia and the other disorders we mentioned before?
So for myself, I have not started on outpatient quite yet, but on inpatient, we do use antipsychotics to help us with the initial manic episode when a patient presents to the hospital. So we will tend to use an antipsychotic initially to help with sleep and to help with some of those elevated symptoms that the patients are experiencing.
Thank you.
So in an outpatient setting, it is very similar. And as Dr. Woodford, as she described, with lithium is definitely our gold standard when it comes to managing mania, but it has some drawbacks to it. Depakote is a semi-distant second. And then we do use a certain set of antipsychotics. So the first generation or older antipsychotics like Haldol and Thorazine, we don't really use for managing mania unless we're just trying to immediately calm or slow somebody down. And if we need to give in the hospital setting, like a shot because someone is so irrational, they're trying to hit their head on the wall or really aggressive towards other individuals, we may need to give a shot to have an immediate impact, but it's not going to have a lasting impact on someone's mood and impulsivity. And that's where the lithium and the Depakote take place as mood stabilizers. But the antipsychotics we would use are what we would call next generation or second generation. So some of the newer antipsychotics that work on receptors other than dopamine, which we mainly use for addressing schizophrenia right now. But they have other impacts so that we can use them to treat, and they have FDA indications for the treatment of manic episodes like Abilify or aripiprazole is another name, Geodon, Zyprexa. We can use those. And there are other medications similar to Depakote that And some people may recognize Depakote because that is also a anti-seizure medication. So we use things like Tegretol, and to a lesser degree, if we're talking about mania, but depression and bipolar, like Lamictal or lamotrigine. So we have a number of medications now, we'll say, for women of childbearing age. We do have to have special considerations for lithium and medications similar to Depakote, because these are agents that can have significant, can cause significant harm to developing fetuses, where there's heart abnormalities with lithium, which is relatively rare, but still clinically significant, versus what we call spinal tube developmental issues, neural tube developmental issues, which are more common and definitely more clinically significant and can be lifelong issues for a child. So we do closely screen our female clients. We don't withhold the treatment, but we have to let them know and inform them, hey, these are the potential risks of this. If one is even thinking about, pregnancy, please, keep the doctors and nurses working with you aware of that, so that we can look at potential changes. And it's much easier and better to do these changes when someone is stable or doing well than when someone is nearing a crisis. And because obviously we don't want any woman to have any complicated pregnancy, and definitely for the child itself to have any long-term difficulties related to that treatment. So in that regard, you will see some psychiatrists tend to lean more towards the atypical or newer antipsychotics when it comes to managing bipolar for women. But obviously there's still a tremendous role for lithium and Depakote either way. But those are things that as a client and potentially for family members to be aware of, and just hopefully all the providers out there are very professional and thoughtful for their clients. And I think I shared this during my last webinar. Is that sometimes we have because of the clientele that we work with, sometimes the patients or clients themselves may not really be fully aware of the scope of their treatment. So someone who's going in again for diabetes or something like that, many people can really be aware, have looked up online, hey, these are the medications that I might be offered. This is the things I expect when I go in to see my doctor or my advanced practitioner. Some of the individuals in our that we treat who have some impairments in cognition or understanding might not be aware of what those needs are. So it's just imperative for clinicians and family members also to just be on the watch. Look up your medications. You shouldn't have any doctor or anybody discouraging you from that. Look up your medications. If someone is recommending something to you, what you're on right now. Unless you're a hypochondriac, I'm a fan of WebMD just for general screening and understanding and having things communicated in a layman's perspective.
Well, I think we are going to wrap up with one last question here. This has been so engaging and the time always flies by. One thing that you kind of mentioned was the concept of, pregnancy and potentially stopping medications. So a audience member on Facebook, thank you to everybody who's watching on Facebook, asked, is bipolar ever situational? So for example, somebody may feel like their bipolar was related to stress. Now they're no longer stressed. They want to come off medication, have a baby. Is there a chance then that it won't come back because now those stressors are gone?
So I wouldn't necessarily say it was situational, but yes, an individual can have a singular episode and not have another one. So similar to what I would say for depression, as I mentioned earlier, if someone is presented to me and they've had a manic episode in the outpatient setting, or if they've had a manic episode and they're in the hospital, I tell them, I'm encouraging them, once they leave my care from the hospital, to remain in treatment, taking medications for at least 6, maybe even 9 months, to again dramatically reduce the risk of having a second episode. Because again, the more episodes you have, the risk you are for more episodes. But there are plenty of people that have just had one episode, similar for a major depression episode, which is again different than being depressed or feeling down. The key here is that they're feeling okay, they've been stable, and they work with tapering off the medications with their provider.
Well, thank you so much. I learned so much tonight that I will be able to apply to my own clinical practice. I really am so appreciative of you both and the knowledge that you brought. Thank you to our audience members, both on Zoom, YouTube, and Facebook, for participating. I am going to bring now the other Dr. Barnett on to close us out.
Thank you so much, everyone, for joining in this discussion. Thank you so much, Dr. Woodford, Dr. Barnett, and Dr. Hill. We are so excited that this series, that we're able to take these topics and really bring them to life in a conversation with physicians and professionals in the mental health field that are very focused and interested in giving back to the community in this way. Please join us next month. Our session next month will be looking at demystifying the superwoman, the idea of the strong Black woman, and how that can be to our detriment when we need to ask for help, when we need support, and being able to take off the cape that sometimes society thinks it's a wonderful thing for us to have, but it could be hurting us and hurting our mental health at the same time. So look out for that flyer, that post. We would love for you to join us as well. This will be posted on our YouTube page if you ever want to share this with someone that is not or was not able to make it tonight. We appreciate all that the committee and you all have brought to this topic. Have a wonderful evening, and we will see you next month.